Hi, my name is Katie Fessler, and today is Sunday, October 6th, 2019. Today I will be presenting my Unit 2 case connections. So the first case that I selected is case 3. In this case, we're presented with a child demonstrating frequent urination and thirst. The blood tests indicate that the patient likely has diabetes mellitus and does not produce enough insulin. Serum levels of insulin are lower in the baby than in a control, both at baseline, which is presumably fasting, and 1 hour after the glucose load is given. This is typically the amount of time you would expect to see an appropriate insulin response. We would expect this patient's fasted blood glucose levels to be above normal range. He also displays some classic symptoms of diabetes: frequent urination and thirst. Insulin is produced by the beta cells of the islets of Langerhans in the pancreas. When functioning properly, these cells produce insulin in a concentration proportional to the concentration of glucose. Increased blood glucose increases metabolic flux through glycolysis and the citric acid cycle, thereby increasing ATP production. This ATP inhibits ATP-sensitive potassium ion channels, which leads to the depolarization of the cell membrane, resulting in increased calcium ion influx. These calcium ions cause the exocytosis of insulin. Insulin has many functions. It will recruit GLUT4 channels from the interior of the cell to the plasma membrane to facilitate glucose entering the cell from the blood, thereby decreasing blood glucose levels. It negatively inhibits cyclic AMP, which is involved in the glycogen metabolism. Cyclic AMP negatively regulates glycogen synthase and positively regulates glycogen phosphorylase. Therefore, insulin's inhibition of cyclic AMP allows glycogen to be formed and stops the breakdown of glycogen into glucose. In this patient, the lack of insulin means that cyclic AMP is not inhibited in glycogen metabolism. Therefore, glycogen phosphorylase is active, and glycogen may be broken down into glucose, further increasing blood glucose levels. This patient likely has high circulating blood glucose. Therefore, fructose 2,6-bisphosphate concentration is needed. This negatively regulates fructose 1,6-bisphosphate by increasing its Km, preventing gluconeogenesis from occurring, and instead allowing glycolysis to occur. My second case is case 4. In this case, we are presented with a baby experiencing jittery spells, fasting hypoglycemia, and hepatomegaly. Of the presented options, it seems that a variant of a glycogen storage disease is a likely diagnosis, but let's discuss why. The first condition is hereditary fructose intolerance. This is caused by the absence of allulose B, which cleaves fructose 1-phosphate. It causes profound hypoglycemia and vomiting after consumption of fructose or sucrose, which will be broken down into fructose on digestion. It will ultimately lead to fructose-induced hypoglycemia, despite the presence of high glycogen reserves, or fasting hypoglycemia. It's unlikely that the baby's symptoms are caused by this. While the baby does present with fasting hypoglycemia, the baby has only consumed breast milk. The primary carbohydrate in breast milk is lactose, which will be broken down into glucose and galactose. She's not had significant exposure to fructose that would cause these symptoms, so we can rule that one out. The second condition is galactosemia. This is the inability to metabolize galactose. It's caused by an inherent defect in one of several enzymes, including galactokinase, uridyltransferase, or 4-epimerase. The unmetabolized galactose may form galactitol, which will accumulate in the lens of the eyes and cause cataracts. If the condition is a result of a defect in the uridyltransferase, it will lead to an accumulation of galactose 1-phosphate, depleting the liver of inorganic phosphate and causing liver failure and mental deterioration. This description does not fit the baby's symptoms, so we can rule this one out. Another option is glucose 6-phosphate dehydrogenase deficiency. In this condition, the deficiency in this enzyme leads to impairment of the generation of NADPH and will ultimately result in hemolytic anemia when individuals with the deficiency undergo oxidative stress, which could be from infection, some drugs, or even consumption of fava beans. This occurs because NADPH is required for the reduction of oxidized glutathione, which is needed to oxidize hydrogen peroxide and to protect the cell. In red blood cells, the pentose phosphate pathway is the only means for NADPH production. The lack of glucose 6-phosphate dehydrogenase stops the pathway from successfully producing NADPH. This description also does not fit the baby's symptoms, so we can rule this one out as well. The final disease is glycogen storage disease, or the inability to use glycogen. There are many variants of this condition caused by a deficiency in different enzymes involved in the metabolism of glycogen. Many of them result in some combination of symptoms, including fasting hypoglycemia, muscle weakness, and hepatomegaly. In this child, epinephrine did not increase blood glucose, meaning that it was not able to mobilize the glucose from glycogen stores. We can presume this is because she has a variant of glycogen storage disease and has an inability to utilize glycogen. Her symptoms fit that of several variants of this condition. When she has consumed milk, which has a supply of glucose, she does not have the hypoglycemia. It's when the glucose source is used up and she is fasting that she has the symptoms.